Okay, first of all, thank you for the invitation to speak. I'm going to try and do this in about 20 minutes. We've got 10 minutes at the end. And I do genuinely want to take questions. So if you don't want to speak to me here, I mean, outside, I'm here for the rest of the day. So please do come and have a chat. And if there's anything we can do to help with whatever your plans are, then do let me know. The Mental Health Act approvals, by the way, that's about approving people for pre-Section 12 doctor and approved clinicians. So not really that much to deal with this. Okay, so why? I mean, obvious stuff really. So 4 key things about why focus on reducing restrictive interventions. Right, human rights, injuries to staff, but injuries to patients or the people you work with as well. I mean, I had a chat with Viv Cooper the other day about a particular individual, and the family complaint, Viv, sorry, is the Challenging Behaviour Foundation, the lead there. And she was telling me about an incident where a family complained to her about the son having carpet burns. It's carpet burns on his head from how often he was being restrained in a prone position. Injuries to staff, I was reading various policies on the train down from Leeds last night, and it was all about how to avoid injuries when you're restraining somebody. I can understand why that's the case, but for me, we sort of come at it from 2 directions. One of them is improving the training that people receive, and I'll talk a little bit more about that later. But the main thing, I think, is about avoiding situations where it's necessary to restrain somebody wherever you can. The last part on here is around money. So I think we've got some colleagues from Merseycare. We have got some colleagues from Merseycare here. They're doing a lot of work at the moment to try and find out exactly what the impact of their No Force First initiative is. You're probably better off talking to them for the latest figures. I'm still waiting for those. But significant savings across the trust. Safe wards, Len Bowers reckons you can save about £8,000 per ward by implementing safe wards initiatives. So, another one. It's not just Merseycare, but I've just happened to have a quote from their chief exec there about getting it right first time. It's common sense, isn't it? If you have to do something 2 or 3 times because something's gone wrong, obviously you end up restraining somebody. Your therapeutic relationship is damaged. Their length of stay is likely to be longer. It has an adverse impact on other patients. But the second one, this was a Minder doing some work with Enson to put together some resources for patients to campaign about reducing restraint as well. And that's just something I picked up from them there. So it's what happens when people don't understand me. A little simplistic possibly, but I think it's a useful quote nonetheless. I've changed my presentation because it got a bit easier. When we started doing Positive and Safe, come to events like this, and it was challenging. A lot of criticism of the detail in the policy, a lot of anxiety about mainly what does it mean for us when there's a violent incident, what can we do to protect ourselves from staff, I think. And there was a lot of criticism of the sort of over-reliance possibly on positive behaviour support within the policy document. But these are the things really, and I've never had anybody come up and say any of those is wrong, what we're looking to do through Positive and Safe. So cultural change, therapeutic environments, doing things within a legal framework. You've got a speaker about that later. So one of the big challenges when we started this work, April last year it was published. I started working on it probably June, July last summer, was we didn't really know. The data we got on it wasn't very good at all. So we commissioned the NHS benchmarking network to do some work to find out what was going on and where it was happening. So this slide's quite instructive really. The red are CAMS services, CAMS forensic and CAMS non-forensic. The green are learning disability, and the blue are mental health services. So I think the perception is that possibly, maybe an uninformed perception, but there's a lot of restraint within secure services, but high secure and low secure, right at the, let's have a look, right-hand side on the, left as you look at it, on there, so very low amounts of restraint. CAM services, both very high. The highest for mental health is PQ, and what you've got there is just over one restraint per month on a 10-bed unit is what we're talking about there, so just over 10 restraints per 10 beds. Can we just check, sorry, who's here from any sort of learning disability services? Okay, what about mental health? Okay, and CAMS? Okay, so we've got a bit of a mix, and some from education as well. I think you were talking about, yeah, I'll come on to a little bit about that later on, some work we were doing with DFE. So, yeah, as you're looking at it on the left-hand side, these are quite high incidences, and I think the CAMS ones is possibly about children and young people maybe struggling with their emotions to sort of control what happens and lashing out more frequently. PQ, my perception on that is often people are there when other services within health can't cope with them, or when they first go in when they're in crisis. So this one pulls out information about a PQ, and this is from August this year. So did any of you come along to the events we've done recently about feeding this data back? No? Okay. Yes. Okay, good. The department is committed to publishing some of this data. So I spend quite a bit of time explaining to senior people within the department and CQC and whatever else about what the data actually says rather than what it maybe appears to say. So if you remember back from the, where are we? Last slide, PQ, it's the highest blue one on there, so just over 10 restraints per 10 beds as a national figure. When you look at it, these are all PQs, this is all for August. So there's a huge range. You go from no restraints in a PQ to, let me just check that, a vast amount, about over 40 on there. So I will be following up with that organisation and a couple of the others on the left-hand side as you look at it, not as a blame thing, but to try and understand why their use of restraint is a lot higher than elsewhere. So a similar thing then for learning disability, but the axis is different there. So your axis there, the highest one there, looks as if there's 310 restraints per 10 beds. That's actually one individual on a one-bed ward who was restrained once per day. So it's just a sort of a warning about what the figures can look like when you don't have that understanding of what's happening. But we also got some commentary from that organisation to say they're actually trying to close that unit down. They know it's not appropriate. They've moved all the other people out there. At the moment, they're trying to find somewhere else, trying to provide a better service for this particular individual. This is a snapshot of the figures during August for mental health, CAMS and learning disability. So there's key ones to pull out really of overall number of restraints. So this is not just prone restraint, but any sort of restraint. 9,600 individuals restrained, 2,600 and some. So people being restrained more than once. Not everybody by any means is being restrained. The background is that I think 23,000 and something beds is what we're talking about. I'm not being complacent here at all. I'm just trying to set the scene and explain what the current picture is. But also some key figures here, I think, about instances of self-harm, violence to staff, violence to other patients. So if you think about the 9,600 restraints, there were a lot more incidents where there was a flashpoint, either some violence or self-harm within that service, within the services, sorry. This one tries to put use of restraint into context again. So you've got one axis is violence to patients, so that's your bottom axis. Your vertical axis is self-harm, and the size of the bubbles is the amount of restraint. So if you look on the, I'm not good at doing this backwards, I'm sorry. The grey one is a PQ, so there's a lot of incidents of violence to patients, and that accounts for the reasons for why there's a lot of restraint. So one way of looking at this is to say that not that it's justified, but there is some explanation for where restraint is used. It's not used where there aren't any incidents of violence and self-harm. That's the small bubbles at the bottom there. It's either where there's violence to patients or where there's a lot of self-harm. That's where you get most restraint. So in a way, that's quite reassuring. But also, it maybe helps us to understand the challenge that you've got. So what's the department doing about it? That's the next couple of slides, really, and I'll take some questions. One of the things we've been doing is to put together a network of champions. So that's people who are, in one way or another, are either seeking to learn from best practice or have got something to share about the work that they've been doing. We've got coming up for 300 people now on that network. We've got events coming up at the beginning of January. It's not so much about having speakers. We will have a couple of speakers there, but it's more about sharing good practice. So I will be trying to buttonhole some people later on to say what exactly it is that you're doing and what success you're having in reducing restraint. But we also had some work with the Federation of Nursing Studies to spread the word about positive and safe. We have it's supposed to be a monthly newsletter, but I'm struggling just weight of work at the minute, so I'm a little bit delayed on my latest one. It's about sharing good practice. So you don't have me standing up and saying you shouldn't be doing that. You have one of your peers who's actually going through it and talking about the success they've had with whatever initiative it is. Now, some of that is about, for example, implementation of safe wards or 6 core strategies, but there's also other things. So we had quite an interesting session. We're going to have some more time from them as well, from Cambridge and Peterborough, where they're really focusing on improving patient care, and as I understand it, that's a big part of what Merseycare is doing as well. So not looking at restraint per se, but looking about how they can improve the sort of environment that people are treated in, the care that they receive. So one of the things is about that Cambridge and Peterborough have been doing is about how they dispense drugs, for example. So rather than people queuing up, they do it in a much more, they have appointments for people to receive their medication when they're on the ward. They do it in private, so you're not queuing up and everybody can see what's happening. There's ways about making environments a bit more normalised, so staff and patients eating together, cooking together wherever possible. Those sorts of things have a very positive effect on the therapeutic environment. And I know that there are risks in doing some of those things, but I think there are also ways of managing those risks. So one of the things we heard at one of the Champions Network was about fruit on one ward being locked away. When they sort of challenged why that happened, it was because somebody threw an apple at a nurse 5 years ago. And they didn't want it happening again. I can understand. I wouldn't want somebody throwing things at me. When these goes really badly, people do throw things, but hopefully not today. But managing that risk really. So maybe on some occasions it is okay. It does make sense to do that, but surely not all the time. This is about my last slide really. So I'll spend a little bit of time on this, then hopefully get some questions from you. So this is what we're doing next really. So clarification. I mentioned it was a struggle at these sorts of events last year. So we are in the process of writing a very, very short addendum, if you like, to Positive and Safe to clarify some of those issues, because there have been changes in the Mental Health Act Code of Practice and then with NICE guidelines as well. I've just started doing some work about training. So what we're looking to do in the first instance is a bit of a scoping work to see what an accreditation of PMVA training may look like for mental health services. For learning disability services, I need to do a little bit more work, but what I want to do is to get the department, NHS England, Skills for Care, all sorts of organisations to say a good service is a service is accredited by the British Institute of Learning Disability through their training scheme. I know there are others available. The work that I've done seems to suggest that it's almost a benchmark for a good service if you've got accreditation through the British Institute. But for mental health services, they don't accredit services for mental health. So I'm looking to do something and say what would it look like for mental health? I'm going into that with an open mind. I know some of the people here were involved in work 10, 15 years ago to have a look at what a system might look like. But one of the reasons that didn't work was because of the annual cost of that system. And everybody knows at the moment, we've got spending review coming up in next week, week after. Cuts to budgets everywhere. So we need a system that's going to work without a sustained input from central government. There's a lot of money spent on this. That's one of the questions I'm asking. How much does your organisation spend on training people at the moment? Part of positive and proactive care, we encourage people to develop restrictive intervention reduction plans. So a organisation-wide plan to say what are the different elements that you're putting together to reduce restraint. So I want to have a look at those later in the year. And then also just see what impact it's having. Is it working? Ask the question. I mean, Merseycare know it's working. Peterborough and Cambridge know theirs is working. Notts Healthcare knows theirs is working. So is your organisation's, is it working? If it's not, how do you learn from somebody else? How you learn is you sign up to get on the Champions Network, come along to those events, find out where other people are having some success. A bit simplistic, but I don't think it's that far off either, to be fair. We're doing some work. I mentioned the education. There was a commitment when we published Positive and Proactive Care, which is for adult services, to do something similar for children. Initially, we tried to do it all within one document, and that just wasn't possible. That has been a real struggle trying to agree with Department for Education what the scope of that document is. But the good news is we've had those very lengthy discussions, and we're now hoping to get something out for consultation early in the new year, which will cover special schools and social care, as well as CAMS services. So hopefully some good news there. I'll stop in a minute, but final point really is whatever strategy you're adopting, whatever approach you're taking, to really think about why, I've said here just when do restrictive interventions happen, but why and where, and what can you do about it? So go back to some of the examples I mentioned earlier about better environments or a particular time of day or a particular staff member or a shortage of staff. We know, for example, that where you don't have enough staff or staff are not well trained, you're more likely to have incidents of seclusion and restraint. So my suggestion would be that actually trying to save money on your staffing doesn't actually help, because you end up with incidents of restraint or seclusion, which means you need more staff, you need agency staff, which are more expensive, and so on. So it's a false saving, if you like, trying to save money there, I think. I know it's not as simple as that, and we will be doing some work around safe staffing as well with NHS England. And the final slide is just my contact details. Again, I'm more than happy to receive questions from people. Where possible, I'll come out and talk to you, visit your service, do what I can to help. But the more likely thing that I'll do for you is put you in touch with people who've had a similar problem and are having some success in dealing with it. So that's it from me, apart from taking questions. So have we got...
Me again, sorry.
It's okay.
People keep saying, why do you keep asking questions and why do you speak about your experiences? Because we need to change, and I need to give people like me a voice. I'm in a different time in my life now, and I talk about health, and thank you for you can comment about this care, but we're not perfect either.
No.
We're striving to be, and that's the thing, isn't it? I'd like to ask about the evidence. You know, when you put the graphs up, and that's wonderful, because we need to, once we see those, we know that there are areas of concern, and we need to do something about that. I'd like to know how you can show, to boost staff morale and show that it's working. You know, when you put the graph up, when we put it up and it shows there's a peak, yeah? How can we show on those graphs that actually how quick we bring that down? So in the past, it's gone on for weeks and weeks and weeks. Someone like me, you know, has been poorly and restraint and all that's gone on. And it doesn't stop, and it's never ending, and you're frightened. So I'd like to be able to show staff that actually you are doing a good job, and how quick you're bringing it back down, and how hard you're working. Because, you know, if we keep saying to staff, you've got to do this, they want to know how they're doing. And when they see that, so how can you do that on your graphs?
Okay. I've actually got one, not for this presentation, which shows a time series. So the first one we did was back in August last year, then we did January this year and August this year. And for most services, it actually shows that either the amount of restraint is stable or it's going down. Now, when we first did this with Norman Lamb, he was very keen and he really pushed for us to collect data on it. And we did the first one and said, here's some data, this is pretty much what's happening. So people are using prone restraint, there's still a lot of restraint out there. Are you sure you want us to collect something which is likely to show it going up? When you increase the focus on something, the norm is that it will go up. And he said, yes, you're only going to, using that as a lever is being transparent. So we collected it again, and I was surprised actually that figures are actually either level or going down in all services. There's more to do. There's a lot more to do, certainly within the highest ones that I mentioned there, within PQ and within assessment units. But I think overall, if I'd been doing this a week later, I could have included a slide for you which showed things either being stable or going down, which isn't exactly what you wanted, but it's a start, I think, on that direction.
It is a start, and I suppose people here today, someone said to me this morning, well, we're from education. Well, actually, everyone needs to know about this, because it's everyone's business, isn't it? And we all need to be doing the same thing. So from children to adults to elderly to everyone learning disability, we need to do that. So thanks for that, and thanks for your kind comments.
Okay.
So just in answer to some of the questions posed, I think we, as an organisation, we're responsible for one of the peaks, and for that one individual, and I can assure everybody that we were working very hard. Yeah. Some of those behaviours were that individual's baseline. The person was out of area, and we were working very hard to try and reduce that baseline, that person's norm behaviours, and trying to keep them safe, and that ended up in restraint the majority of times. He's now being discharged back home, so I think that is a success story. Yeah. And it was a lot of hard work and a lot of dedication and a lot of PBS planning, and it started us on the road.
So I hope I didn't give the impression that I was blaming or saying that was a particularly bad organisation. I certainly didn't mean to do that. I was trying to explain the graph.
Thank you.
Okay.
Hi. With cuts to department budgets, how are you going to keep restraint at the forefront of people's minds within the Department of Health?
Okay, it's a good question. I mentioned a minute ago in one of the answers about Norman Lamb being really a driver for some of this work, obviously within the coalition government. I had a meeting with Alistair Burt a few months ago. He's the minister who's now responsible for it, and it was through a discussion with him that we started the work on training. Both ministers in Department for Education and Department of Health have looked at the work we're planning to do for education for children and young people. They both agreed to us doing that. The programme was due to stop it was a 2-year programme when it was first announced, which would have been April next year. But Alistair Burt said, no, you need to carry on doing it, carry on working on it. So I think there's a continued commitment from ministers to do it, but there is a challenge, and that is that there isn't a great big team doing this. So it's mainly me, and then there's a few other people who've helped in the past who've now moved on to do other things. So at the moment you've got me doing this for 3 days a week. So there's a commitment, but there's also an acknowledgement that I maybe can't do as much as I'd like to do because of the, I'm only human. But hopefully, there is definitely a commitment to carry on working on it.
Hi there. Build right now only accredit training that has a physical intervention component. And I'm just wondering, as physical intervention training should sit amongst the PBS framework, is there a plan to accredit PBS training?
It's a good question. There was a proposal from a lot of organisations who work on PBS to develop a PBS academy who would be responsible for that accreditation. It was quite a lot of money needed to start that organisation up, and then the cost would tail back over a couple of years. But,
Sure.
there isn't, but the fund that Marie mentioned at the beginning, which is a massive struggle to get that money out of the department, but we managed to do it, and hopefully, if we get some funding next year, we'll do the same, and we'll do it a lot more, be able to do it a lot more quickly. Part of the way that we're administering that fund is we've got an academic, we've got a service user, we've got Marie, who won't let me do anything strange. So there is a sort of a quality component in that. So when people put in a bid for that funding, we will check that the funding is being provided by a reputable provider. But in terms of quality of PBS, you're probably better off having a chat with Marie rather than me, to be honest. Is that okay?
Yeah, no, okay, thank you.
Yeah. We done?
Any other questions?
Okay. I'm around for the rest of the day, so if there's anything I can do to help anybody or any more information I can give, then please do have a chat. Okay, thank you.